Hey Don, are you there? First, a little information regarding Zoom. You are all on mute to prevent background noise and feedback. Please type any questions you may have into the Zoom chat function and they will be answered at the end of the talk. This call is being recorded and will be available on the IAPA website in the near future. Tonight, we have the distinct pleasure of welcoming Jonathan Baker and Don Martinez, who will be co-presenting tonight's talk. Jonathan Baker is a PA at Laser Surgery Care in New York City, specializing in anal pathology with a focus on HPV and other STIs, and conducts NIH-funded clinical research. Jonathan is past president of the Lesbian, Bisexual, Gay, and Transgender PA Caucus, and founded the LBGT PA Caucus Speakers Bureau, which promotes education on sexual and gender minorities throughout the US. He serves on the board of the New York State Society of PAs as the New York City District Director and has recently been elected as president-elect. Jonathan is a frequent speaker at national, specialty, and state CME events, including AAPA. He is published in various peer-reviewed medical journals, including JAAPA, and received the AAPA Award in Clinical Publishing in 2015. Jonathan is celebrating his 10th year as a practicing PA. Don Martinez has been practicing for 13 years, the last 9 years with Advocate Aurora Health. Currently, Don sees pediatric patients, but has extensive experience in family medicine. In addition to his clinical roles, Don serves as the professional development lead for advanced practice, implementing and designing programs to support and enhance PA and APRN practice. Don also serves as adjunct faculty at Midwestern University for the PA program. He began his first term as an AAPA delegate with IAPA in 2020. Prior to becoming a PA, Don was a social worker specializing in HIV prevention, counseling, and testing as a certified community health outreach worker. Additionally, Don has a 20-year history as an established speaker advocating for the GLBTQ community. So without further delay, here are Jonathan and Don.
Hi, good evening. Thank you for having me and thank you for the introduction. We are so happy to be here, and I really want to thank NYSSPA and IAPA for their commitment to diversity, and not just on this topic, also on racial diversity. I know IAPA just had a wonderful webinar. NYSSPA put out a really strong statement, and we are committed to that. So I appreciate everyone being on. I appreciate having this opportunity, and I'm going to jump in here. If you have any questions, please feel free to share in the chat, and Don can answer while I'm talking, and I'll answer while he's talking, and then at the end we can kind of review some of the stuff that might have come up as you have any questions. I see a lot of familiar faces in the participant list, so thank you all for joining. All right, so I wanted to begin with a case here. So Jacqueline is a new patient to your practice. She's a 50-year-old female who recently moved to the location of your practice. And on our intake forms, you see a past medical history of hypertension on lisinopril, and otherwise nothing too exciting. They're a little bit incomplete though. At the front desk, she's greeted and is told, "This must be your husband's insurance card. Do you have yours?" Jacqueline's ID and insurance card have the name Daniel. Jacqueline feels unwelcome and leaves. She knew when she saw the intake forms, which had only the gender options of male and female, that maybe this practice wasn't going to be welcoming to her as someone who was assigned male at birth with the name Daniel, but identifies as female and goes by Jacqueline. So I just want to take a moment and reflect on this case. And first of all, how does that make you feel? What thoughts kind of go through your head as this is happening? And feel free to share in the chat. I know everyone's muted, but if you want to share any thoughts that you have, I actually can't see the chat from here. Let's see if I can bring it up. Is my screen not shared right now?
No, it's not shared.
All right, let me, sorry about that. Okay, there we go. Now I have the screen share and the chat open. Okay, so you didn't miss anything on my slides about Jacqueline. You got the story. So how does this case make you feel? We're just from the very get-go, this patient experienced feeling unwelcome, even from just filling out that intake form. What about her prognosis? What is Jacqueline's prognosis? Is she going to come back to this practice? Is she going to go find somewhere else? Jacqueline's 50, she's due for her first colonoscopy. You know, what's the chances that she's going to go get her colonoscopy?
Jonathan, I think from prior discussions you and I have had about this, the first thing I think about is assumptions, that the office is clearly making assumptions that there are only two genders, that they made an assumption about the naming of the patient. They made an assumption about the gender identity of the patient. You know, and this is something we need to move away from.
Yep, absolutely. And so my last question on the screen, Don's going to address, which is, who could have prevented the situation from occurring? There's no provider involved in any better part of this. There's not one single PA involved in this at a very superficial level. But one of the things that we really want to encourage are some best practices that you can implement in your practice so that this type of thing doesn't happen and that patient can actually get to you. I recognize that the people who are on this presentation are self-selected. You've chosen to come to this. So my guess is that you have some baseline cultural sensitivity, but that doesn't get you anywhere if your patient doesn't actually make it to you. So let's look at some basic stats here. So Barb, sorry, I changed the name of my patient. She was Barb originally, she's now Jacqueline. But neither Barb nor Jacqueline are alone. Over half of LGBTQ individuals report experiencing healthcare discrimination. So much so, 10% of LGB and 30% of transgender and non-binary patients have been fully on refused care. And once patients do experience some healthcare discrimination, they're 3 times more likely to postpone care, and that includes things like refilling their blood pressure medication, like in our case with Jacqueline. And then when we look at intersectionality, which we'll get to, LGBTQ people of color are more than twice as likely to avoid a medical office than white LGBTQ individuals. So when we think about our prognosis for our patient, it's not great. There's a good chance that this patient's probably going to postpone care. And again, there's a lot of things that this patient needs as they've recently turned 50. So some basic terminology. Again, I recognize in the room there's probably people who are like totally experts and people who may be more novice. So just some basic terminology. Gay is generally same gender sexual attraction. Bisexual, sexual attraction to more than one gender. Typically thought of as very binary, as male or female. Heterosexual, sexual attraction to the opposite gender presenting patients. Non-binary is where the behavior or appearance doesn't conform with gender norms. Transgender is where the assigned sex at birth doesn't match the gender identity. Intersex is sort of a discordance between anatomy, hormones, where it just doesn't quite match up. And queer is just a concept of diversity beyond heteronormative culture. But what I want to get to with these definitions is you have sort of 2 sets here. So the first set is really looking at sexual diversity, looking at different sexual attractions. And when we use the term gay, it's really kind of a privileged term. A lot of what I want to impress on you is that a lot of the patients who really need the most sensitive care from us are probably those who don't present as gay, who don't get to use that term. They may have some situation or some other focus in their life where, unlike me, where I can walk around and be an openly gay man in New York City, be an openly gay healthcare provider, not everyone has that luxury. And then when we look at the other set of terms, this is really gender diversity. And these are sort of exclusive of each other. Someone can be transgender and gay, someone can be non-binary and attracted to multiple genders. So it's two sort of different categories that I think sort of get lumped together, like people have to identify as just one of these. And people, quite frankly, don't have to identify as any of them. So I think this is probably the best presentation of gender and breaking it down into little pieces. And it's so simple, you can look at this and tell that it's made for a child to understand. But I think that it actually applies really well. So we sort of start with sex assigned at birth. So when someone is born, we look at their genitals and determine if they're male or female. And then they're assigned a sex. And that's the end of story. In the US, generally, it's male or female. In other parts of the world, there's a little bit more diversity. But it's really based on genitals, right? We don't do genetic testing. We don't look at what sex chromosomes someone's have. It's really just looking at genitals. Gender identity is the way that someone feels. So this is the gender that someone identifies with. This could be a more male identity. This could be more female. This could be other genders. This can be a spectrum between them and some combination of those, which is a little bit different than gender expression, which is the outward expression of gender. And this might be, again, more feminine, more masculine, or something else. And these don't necessarily match up with the identity. Just because someone identifies as female doesn't mean that they're going to present in a very feminine way. Then there's physical attraction. So this is sort of looking at, again, at that sexual diversity side of things. Is that person attracted to men, women, other genders, multiple genders, all genders, no genders? And then emotionally attracted. So there's a little bit of a differentiation here as well, where the emotional attraction might be different from the physical attraction. So just to put some sort of examples here. So I was really fortunate to have been assigned male at birth and to identify as a male and to present myself generally as a pretty masculine presentation. And then it's straightforward for me. I'm physically attracted to men. I'm emotionally attracted to men. For our patient Jacqueline was assigned male at birth, but identifies as female, uses she pronouns. We didn't get into what Jacqueline's gender expression might be based on the assumption of the front desk person. It's probably somewhat of a feminine presentation. And we didn't talk about who Jacqueline's physically attracted to. So they assumed that Jacqueline was heterosexual and had a husband, but Jacqueline might be attracted to women. And if that's the case, then Jacqueline would be considered a lesbian. Or Jacqueline might have a more expansive attraction than just one gender. So I saw Deb Dunn is on here, which I absolutely love because I stole this idea from her. I am not gender non-binary, and so I don't feel that I can give you the words to describe what gender non-binary is. And so I went to Deb's awesome presentation at GLMA last year, where she went through a couple of people who identify on the binary scale. And one of those people was Sam Smith, who's a well-known celebrity. And so I used this quote that was in Vanity Fair from Sam Smith to help describe what non-binary is. And so I highlighted the part I'm going to read to you. Non-binary or genderqueer is that you do not identify in a gender. You are a mixture of all things. You are your own special creation. Do I want a sex change? It's something I still think about. Do I want to? I don't think it is. So I think there's a lot of misconceptions about what gender non-binary is. It just simply isn't matching up with one of these binary genders that are relatively arbitrary, that our society finds to be very, very important for whatever reason. And that takes me to pronouns. So when Don introduces himself, also his pronouns or he pronouns, mine are the same. as you can see, I have them displayed on my lab coat, and it's not that I'm concerned that someone's going to misgender me. Again, my gender expression is fairly male. It's not a concern of mine, but I want my patients to know that if their gender doesn't match what I might think, or they want to ensure that I'm going to use the proper pronouns, I want them to feel that they're in that safe space where they can share that with me. A lot of people have an issue with the word they. When you're describing someone who doesn't use he or she pronouns, maybe they use they or many other options, whatever works for them. But they was Merriam-Webster's word of the year last year, because it can be used to describe one single person. So a lot of people grammatically have a problem with this. Well, Merriam-Webster says you're wrong. We can call people they. As an individual, they can be they. So I have a lot of friends who just get hung up on that, but I'm going to trust Miriam on this one. So I wanted to talk about cultural sensitivity and sort of give you an idea of what my community has experienced in the last 3 or 4 months. This has been a really hard time for everyone. And so I just brought up a couple of news stories that we've seen just very recently and sort of how this has affected my community. So huge pandemic going on. Everyone has experienced all kinds of aspects and facets of this, but a lot of things in particular for the LGBTQ community. And it begins with sort of less access to care. Maybe we don't have healthcare providers that we trust, and some echoing of HIV stigma, and this virus that's stigmatized, that's causing problems. Really sort of echoes some of those ideas. And meanwhile, those people who are caring for COVID patients have the possibility of losing their job simply for being gay. This is Mia McDonald, the president of the LGBTQ PA Caucus, and Mia worked in the emergency room in Greensboro, North Carolina, where she could have lost her job simply for being a lesbian, and was caring for frontline COVID patients. And then the Trump administration in Pride Month, in the month of June, on the 4th anniversary of the Pulse nightclub shooting, the Trump administration decided that the Affordable Care Act protections that protect someone based on sex did not extend it to LGBTQ individuals, which was the interpretation that the Obama administration had used. So a big hit, but then the next day or 2 days later, the Supreme Court sort of disagreed with that, and a huge case where they decided that the 1964 Civil Rights Act that provides a basis of non-discrimination on sex actually does apply to LGBTQ individuals. This is specifically in the realm of employment, but it's really big because when the Supreme Court sort of comes up with a definition for something, it becomes meaningful in a lot of other ways. And then to compound all of that, we see this eruption of racial justice based on some really terrible things beyond the scope of the presentation. But the modern LGBTQ movement was started by a Black trans woman. And since then, these have been inextricably linked. We cannot have gay civil rights without having civil rights based on ethnicity and diversity. These are one cause, and it is really important that we are supporting each other, and that these communities and that other communities see that these are all intrinsically linked. Okay, so getting into a little bit of medical stuff here, and I'm just gonna briefly touch on this. Some of my sort of pearls are focused on what you know. So if you don't know sexual and gender minority health, that's okay. Do your best. But focus on what you know, and what you do know is anatomy. As PAs, that's something that we're really good at. So during sexual history, focus on anatomy. Find out what's touching where, and then you know what your patient's at risk for. Use gender-neutral terminology. Genitals is a really simple way to talk about genitals in a gender-neutral way. Maybe your patient has a penis, and maybe they don't want to have that penis, or maybe they don't associate with their penis. Genitals is just like a nice, easy way of saying that. And you want to really screen, treat, immunize, think about your patient's anatomy and what they need, but also in context, think that they may have some adversarial relationship with their anatomy. So if your patient has a cervix, and has to be screened for cervical cancer, but they're not a fan of their own cervix, that's okay, but they still need that screening. And so you need to meet your patient where they're at and find some way to get them appropriate care in a way that's meaningful to them. These are some of the most important themes in sexual and gender minority health, and some of these apply to certain populations more than others. One of the main ones is coming out to your healthcare provider. Only about 16% of LGBTQ individuals are out to their healthcare provider. So that's 84% of patients who are missing out on some needs that they have. A lot of issues with cancer, and again, this goes back to think about what your patient's anatomy is and finding a way to screen for them that works for them. Vaccinations are really important for hepatitis, which I'll get into. A lot of mental health concerns I'll come to. Tobacco, substance use, alcohol are increased in certain sexual and gender minority populations. Obesity is common in certain sexual and gender minority populations as well, so thinking about fitness, and then all of those culminate into cardiovascular health, of course. Intimate partner violence is not specific to heterosexuals by any means, and is really rampant in certain sexual and gender diverse populations. And then sexual health, STIs, and protection. A lot of times I see presentations that sort of line up like, do this for lesbians, and do this for gay men, and do this for transgender people. And I'm not a big fan of that because there's so much fluidity and there's so much variation that I don't think we can just throw people into boxes. And so I just wanted to give you an example of how I think about sexual and gender minority health. And my focus is on colorectal surgery in my practice. So this is what you would think about for a patient who's engaging in anal intercourse, not because they're a gay man, not because they're a transgender woman, just someone who's engaging in anal intercourse. Think about vaccinations, their risk for HPV and hepatitis B. If they're engaging in oral anal sex, they're at risk for hepatitis A because it's oral fecally transmitted. 3-site screening, so finding out what body parts touching where and making sure they're being screened there. Blood tests for syphilis and HIV if at risk. Sexually transmitted enteric infections. So again, if your patient's engaging in oral anal sex, they may be at risk for things like Giardia or histolytica. Some HIV risk. Receptive anal sex is the highest risk sexual behavior in terms of HIV transmission, followed by insertive anal sex, and both of those are more risky than vaginal sex. So just the physical act of anal intercourse has a high risk of HIV. Consider PrEP, which is oral medication to prevent HIV, and be aware of U=U, which means that someone who's on HIV medications and their virus is suppressed to the point of not being detected by commercial assays, those people cannot sexually transmit HIV. Consider an anal PAP. There'll be a little bit of that in the resources, again, a little beyond the scope of this. But newsflash, this doesn't actually just apply to sexual and gender minorities. This is a survey of 20,000 heterosexual individuals, and about 30% of heterosexual individuals report engaging in anal intercourse. And condom use is fairly low because often condom use is used for contraception among heterosexuals. So really a lot of healthcare things that you can apply to a lot of your patients. When it comes to mental health, across the board, all sexual and gender minorities have increased risk for anxiety, depression, personality disorders, basically all of it. You name it, we're at increased risk for it. But it really gets worse in certain populations. So gay and lesbians at increased risk. When we get to bisexual, we start to see a significant increase. But there's some really interesting research that shows that the group that actually has the most mental health outcomes are those who mostly identify with one group. So someone who's mostly bisexual. And the theory behind this is it has everything to do with community. So gay and lesbian, we have our community. Bisexual has a smaller community. There's often sort of a double standard where someone who's bisexual may not fit with the gay community or the straight community. When you get into someone who's mostly bisexual, they've got like the smallest little community, and we see poor mental health outcomes because of that. And then we compound that with other issues like race. And so we have overlapping minority statuses. This is called syndemics, sexuality, race, and other cultural norms. And these translate into negative outcomes like increased HIV and STI risk, increased condomless sex, or mental health and substance abuse, and certain factors that add to that, like low socioeconomic status. So these sort of non-traditional risk factors become risk factors for things like HIV and STIs. And you see for protective factors, informal or formal support network. So having community, having family who are aware of your status. Aging and sexual gender minorities is a very hot topic for a big reason. The traditional definition of successful aging is decreasing risk of disease and disability over time. However, there's a lot more to it. And so this is a more complete definition: maintaining cognitive and physical function, continued social engagement. And so what LGBTQ people need for successful aging, the data shows that we need self-realization of our orientation, so understanding who we are and coming to terms with that, and the support from families, and that can be our biological families, families of choice. We need access to LGBT services. We have specific health needs that we've talked about already. And over time, dealing with these crises as a sexual and gender minority results in resilience and an ability to get through difficult situations. So I am going to hand things over to Don here. It is all yours, buddy.
All right, thank you, Jonathan. Just really quickly before we jump over to best practices, one comment had come up and I just wanted to address it very quickly. And I will be completely transparent in that this is actually a concept I struggled with a lot trying to understand, and I'm still even not that great at teaching it. But the difference between gender identity and sexual orientation, and how people may identify as a person who was born male, wants to be a female, but then identifies as a lesbian, and just how the differences and kind of the interplay between those two constructs are. So that had kind of come up in the chat. So I think, I don't know if you could just speak to that for a moment, kind of how they kind of diverge, I guess is the best way to explain that. So I think there's generally, I guess what I'm trying to say is there's generally seems to be a lot of confusion about that, and how does somebody who may portray as a, hang on one second, let me get the exact phrasing here. But I guess, yeah, somebody who identifies as female as like just the concept of how a person can identify as a sexual orientation and their gender may not always match. And I think the take-home message that I always try to explain to people is that they kind of exist separately. So gender identity is something completely different from an orientation. And I think your slide, if you want to pop back, yes, perfect.
Yeah. So these are basically mutually exclusive concepts that we're sort of conditioned to think of them as overlapping. You know, and I give the example of myself where it just sort of lines up and I hit just all of those male check boxes and it's like simple and straightforward. But anyone could be on a spectrum of any of these. I didn't put sexual orientation and expression on here. Well, I actually didn't create this, so I did not put it on there, but I didn't include discussion of it. You know, someone can be sexually attracted to women and engage in sex with men for certain reasons. You know, and some sort of cliche examples of that, but you know, gay for pay porn in like a prison setting or that sort of thing. And there's, you know, there's a lot of theories about sexual diversity, and probably more people are bisexual or pansexual than we realize, and the stigma associated with those identities makes it a lot harder to have that identity, and so people sort of put themselves into a box, which is unfortunate because they're missing out on what could be some enjoyable and fulfilling times with people of a gender who they wouldn't necessarily think of as sexual partners.
Thank you. All right, so let me just pull my presentation up really quickly. So first off, I want to thank the IAPA and NYSSPA for having us this evening. Jonathan, it is great to present with you. I know we actually connected in a very unconventional way over Instagram, so it's great to actually present and work with you. And thank you to everybody coming here. So I just wanted to very briefly go through some best practices and tips on how we can incorporate some of the concepts that we've talked about tonight into our own practice. Now, a lot of the tips, now first off, this is not exhaustive. This could be a 3-hour course all in of itself. And a lot of the tips here are really designed for what we can do at the practice level. There are a couple of call outs to where we could do things more in a larger scale, but really this is how you can start impacting change at your practice level. So I'm going to start off with a case study as well. So Kyle is a 22-year-old cisgender gay man. He has been a patient at a primary care office for about 2 years. He's been seeing Dr. Smith there regularly. But this particular day, Dr. Smith is out of town, and Kyle decided to see the PA for the very first time. He's had a persistent sore throat, fever, and enlarged glands in his neck for the last several days. He said it hurts to swallow, and he has tried kind of the usual over-the-counter stuff with no improvement whatsoever. It is noted in his chart that Kyle works as an HIV prevention counselor and is frequently known to hang out at the gay hangouts in the youth shelters. Recently, the adolescent youth home he has volunteered at has had a strep throat outbreak. So Kyle is not out, which basically means that he is not open about his sexual orientation to his friends or family at this point. Although he is assumed to be gay by his peers. At this point, he has also not had sex. So Kyle begins his visit with the PA. He starts to explain his symptoms, where he is very quickly interrupted by the PA. The PA begins to ask about his HIV status and sexual history. Kyle becomes so nervous that he doesn't finish giving his full history. Kyle is told he has a viral pharyngitis. He is also given pamphlets about safe sex and a referral for an HIV test at the community center where he works. Kyle ends up at the ER that evening due to the excruciating pain in his throat and his inability to eat or drink due to the pain. At this point, he's diagnosed with strep throat and dehydration. He is kept at the ED for several hours and treated with fluids and antibiotics. So just a couple questions to ask. First off, what assumptions were made about Kyle during this encounter? And did these assumptions put the patient in harm's way? So what happened to the patient because of these assumptions? What collateral damage could have occurred as a result of this patient encounter? So based on this encounter with the healthcare system, how could Kyle's perspectives have been changed about his future care? And how would you feel if this was you or somebody that you cared about? You know, and in this particular case, the outcome ended up involving a little bit more money. Going to the emergency room involved a little bit more treatment than may have been necessary if this had been treated promptly. Unfortunately, did not result in harm to this patient, but it had the potential to. And long term, this patient may be more reserved about sharing his history with his next provider because of the situation that he had experienced. So for all of us in healthcare, this should be a very common construct here, which is the patient experience. And I just wrote this slide from the ambulatory or outpatient perspective. And the reason I always start these talks off with this is just to put yourself in the mindset of what a patient goes through when they come in to see a provider. You know, to us, this just becomes a normal course of the day, but to the patient, there's a lot of different things that go on throughout this process. So they come into the office, they go through the registration process, and everybody's favorite, they get to hang out in that waiting room. So they are usually called back, hopefully not too long of a wait there. They're brought back, and they usually have an intake with either a nurse, a medical assistant, medical office assistant, tech, and then they spend some more time in that room waiting for the provider. So the provider then walks in, takes the history, starts building the patient's chart if they're a new patient. Then there is the physical examination, medical decision-making, counseling, referrals, and discharging that patient. And then the patient then works with the referral coordinator, discharge planning, or maybe just the MA or the RN to get all of the papers that they need to go on to their next stage of care. So pretty commonplace, something we're all very familiar with. You know, but when you look at it from the new perspective, this is what that new patient coming in to see us for the first time sees on the other end of the spectrum. First, lots and lots of time waiting. Lots of time to stare at the walls, observe the office, take note of what's in the office, take note of the interactions, take note of how the staff behaves. Lots of time to do that. It can be very intrusive. You've got a lot of historic data collection going on. You've got 2 to 3 staff members at least 2 to 3 staff members you interact with. So somebody at the front desk, somebody rooming you, your provider, and maybe even a person after that fact. If you're in the hospital, you've got a heck of a lot more people coming in and out. You've got nurses, techs, dietary, testing, whatever else may be going on. There's handoffs. So each, your visit, your health information, your history is being given to, 3 or more people per visit average. And all they're thinking in their head is, please, 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 no rectals, no pelvics, no needles, no shots, no bad news. I just want to get through this and get home. But for a person who is a gender sexual minority, it can be even a little bit more intense because they also tend to have some information they may not be comfortable sharing. So, when they walk in, they don't know a provider's personal beliefs or the beliefs of a healthcare organization. Some healthcare organizations are restrictive about the type of care that they can provide based on certain religious factors. Previous mistreatment in the healthcare system, as Jonathan shared earlier, the statistics for mistreatment of LGBTQ plus people in the healthcare system can be huge. So they may have already had that experience. You may be getting information from the patients that they typically or may not be sharing with anybody else in their life. Whether it's the fact that they are gay, lesbian, bisexual, if they're feeling like their assigned sex doesn't match their gender identity, if they are particularly scared because they think they might have been exposed to a disease, they might have been exposed to HIV, you may be prone to or you may be privy to things that they would not ordinarily hear. And then there is still stigma from underlying conditions or past medical history. I think that particularly if you talk to people who went through the 80s and the 90s, there is a lot of stigma even to this day about HIV. There were a lot of assumptions made about people who may have been exposed to HIV. So they may have that. And then finally, especially with gender sexual minorities patients, you may notice that they are dealing with sometimes internal homophobia, transphobia, biphobia. I should have added all those, I apologize. But where they have taken on some of these characteristics for what they've experienced in their own life prior to coming into the office. So a lot of the practices and the things I'm going to walk through tonight with you in the next few minutes come from the GLMA, who at one point was the Gay and Lesbian Medical Association, who have kind of dropped that, but have become GLMA, Health Professionals Advancing LGBTQ plus Equality. They've got a really great guide on their website for the care of lesbian, gay, bisexual, transgender patients. Lots of information on there. I've included the link. We will send out a handout after the presentation. They've got a lot of information on their website. I will caution you, some of their publications are, I think the most recent edition of this was 2006. So there have been some substantial changes in a few of the elements that they bring on there. So if there's any clinical pearls, I would always double check to make sure you have the most recent up-to-date information on that. But it's a great article. So what I wanted to do is just kind of walk through a couple key points about the patient experience and how we can start impacting change along the way. So making the wait pleasant. So from the get-go, I think it's important to recognize that GLBTQ patients, like everybody else, are diverse. There are cultural, racial, socioeconomic differences. So a lot of times everybody kind of get lumped into this acronym soup and then becomes a community. And while there are certain degrees and certain common threads that I think a lot of folks will feel within this group, that does not necessarily mean that we all feel the same struggles, we all feel the same, the same passion and dedication about particular issues. So it's important to recognize that it is a diverse community. So when you're in a waiting room, you should make sure that you have materials that are representative of same-sex couples and families, as well as traditional family structures, and including gender diverse people. So you really want to embrace all of the different community that you serve in your waiting room. And that is a very subtle way from the beginning to let people know that this is a safe place to come in and to get healthcare. Add sexual orientation to the organization's non-discrimination policy. Now, most of us on the clinical level don't have that power, but we can advocate and encourage that change to be made. Certain subtle things, such as having a unisex bathroom, can help ease nerves, especially for gender minority patients. So patients that may not feel comfortable going into a bathroom, you know, if their anatomy does not match their gender identity, they may not feel comfortable going into a bathroom. So just even having that slight opening, and of course we all go, okay, unisex bathroom, no big deal, but to somebody who is in that situation, having that safe place to go, even just to go use the washroom, is amazing. And then observing relevant days of recognition, Pride, World AIDS Day, and I believe there's a Transgender Remembrance Day, but making sure that we call out and celebrate certain things like that. I know the organization I work through did a huge Pride recognition campaign. So we all got to send in pictures for how we celebrated Pride, and that was displayed all over our organization. So that was a great way to recognize and let patients know that we are accepting and want patients to feel comfortable. So sexual orientation and gender identity data collection, and this actually comes from the CDC, and this was just a really great quote that I thought that really underscored why this is so important and why we want to spend the time getting to know this information about our patients. But without this information, lesbian, gay, bisexual, and transgendered patients and their specific healthcare needs cannot be identified. The health disparities they experience cannot be addressed, and important healthcare services may not be delivered. And I know that each and every one of us go into the office every day to do the best for our patients. That's why it is so important to really understand our patients and to know what they need from us. So registration and intake, asking the right questions the right way. So this goes back to Jacqueline and Barb, and talking a little bit about that experience and how we can take some practical steps to make that uncomfortable. Number one, allow for more than just a male or female when you're identifying sex. So whether it's a little checkbox on a paper, whether it's scripting that you follow and enter into the computer while you're working with the patient, but allowing them the opportunity to identify what is the most appropriate way to identify them within the computer system. And then remembering that gender and sex can be two very different constructs. I would also strongly encourage you to allow patients the space to share their preferred pronouns and then respect and use those pronouns when you are talking to the patient. Options to express sexual orientation, and making sure that you're using open-ended options, because there are a lot of different elements to the spectrum. And what I have found in practice is, you know, it's far beyond gay, lesbian, bisexual. You know, there's pansexual, asexual. So allowing people to be able to share where they are at within their expression and orientation. Using neutral language for relationship status. So even moving away from calling it marriage status and moving it into relationship status on your paperwork. Considering terms like partner, civil union, domestic partnerships, or other legal relationship status in your state of practice. So for example, in Illinois, prior to June of 2014, people could enter into a civil union, but at that point it was not a marriage equivalent. So it was a civil union or you were married. And if you were a same-sex couple, you had to go into a civil union versus a marriage. So in Illinois, we still have people that did not, when marriage equality came through, chose not to become married and still are in legal civil unions. So that's in Illinois a legal relationship definition. So be mindful of that in the area that you practice. I would strongly encourage, avoid that tag of married same-sex as a qualifier for relationship status. Married just by itself works well, especially if you've incorporated other areas for the patient to identify their operations or their orientation. Always remember, the intake forms will give you some information. They'll give you the foundation, but you don't know necessarily what the house looks like. So be sure to follow through on what you're talking about. Be sure to be prepared to discuss in detail. And most importantly, be comfortable with that conversation to follow. I think one of the key tips and the key takeaways from our patient presentation earlier was that the insurance card may not have matched the person in front of you. And, you know, if you're looking at it, you do need to obviously question that, but it's not that you're questioning it, it's how you question it, it's how you approach it, it's how do you build that conversation to help that patient to feel comfortable enough to say, well, that's my legal name, but I prefer to be called Jacqueline or Barb. So that's the trick. It's not that you're wrong for questioning it. And I don't like to say wrong because you're doing the right thing. You're making sure that this patient in front of you has the right insurance and identification. It's getting that story. So just being comfortable and having a script inside on how to ask those questions sensitively. And is it appropriate to do it at the registration desk, or is it appropriate to, you know, maybe you have a process whereby you flag the provider and say, hey, just so you know, this didn't really match up. I didn't want to embarrass the patient, but then in a one-on-one conversation, I can, you know, bring that concern up in a sensitive way to help that person after I've built rapport with that patient. So there's different ways to handle it. And then again, like the waiting room, assure the literature in the exam room is inclusive and representative of all of the patient demographics that you serve. All right, the dreaded EMR, because all of us love electronic medical records and we always love trying to navigate getting all of our information in there. So a couple key points to keep in mind when working with an EMR. Remember that sometimes the patient's chosen name may not match their legal name. So we want to make sure that we have some type of safety mechanism built into the medical record platform to allow the patient to identify their preferred name. And then not only identify that, but then any relevant paperwork, discharge summaries will also have that patient's preferred name versus their legal name. So looking at how we can make our EMR very comfortable to our patients. And then also making sure that we have a way to accurately and safely record gender identity, orientation, pronouns, transition status, if appropriate, etc. You know how to use these tools if they were available. If they're not available to you, ask for them. Because again, this is one part of getting the information necessary to make sure that you are giving your patient the full and complete care that they need. Patient interviews. So trying to move towards comfort in what can be an uncomfortable situation. You know, I work in pediatrics. I've worked in pediatrics for the last 5 years and family medicine for many years before that. And, you know, I've been doing it for years. It's still a little uncomfortable when you have to talk to teenagers about their sexual practices for the first time. I get it. So, you know, it's trying to become comfortable with some of this, especially if it's stuff that you may not be familiar with, or you're not sure how to answer because you don't want to create a level of uncomfort for your patient. So sometimes it's just identifying ways to convey your willingness to discuss sensitive topics, letting patients know that you're open to having those conversations. I think this is a really key takeaway when you're having a patient interview, is don't assume anything. Don't assume sex, sexual expression, gender expression. You know, they can all vary greatly and they can depend on a multitude of outside factors. You know, people often have times where they may not disclose the fact that they are gay, lesbian, or bisexual, or in a same-sex relationship for a number of reasons. Maybe they're worried about the impact it would have on their career. Maybe they're worried about, you know, the perceptions of their community. There's a lot of different reasons that people can be careful with that. So don't ever make that assumption and let patients kind of guide the way with that. Always discuss sexual health openly with patients in a non-judgmental manner. You know, I think I learned this, I will be honest with you, doing community health outreach work. You know, I was a bright-eyed, bushy-tailed 22-year-old social worker, and my goodness, some of the stuff that these people would tell me, and it was just, you know, for me being that age was mind-blowing because it was just, I didn't realize. So it really took me a while to be comfortable with having those conversations and finding ways to allow patients to explain to me their practices and not have that judgmental side, so that they knew that I could help guide them on how to engage in safer practices. Normalize the questions that I ask with your patients. You know, I always ask teenagers, you know, are you having sex with men, women, or both? And I always paraphrase that as, this is something I ask everybody. I'm not picking on you specifically. You know, and if you're not sure, and I think Jonathan brought this up in his talk, ask, but just be gentle about it, you know, and don't expect the patient to teach you everything about that particular issue. You know, take the initiative, do a little research outside of that patient experience, but do give that patient the ability to share their experience. You know, speaking from a personal perspective, it can get exhausting when you have somebody who may not be very familiar with, you know, quote unquote, the gay lifestyle, and they sit there and want you to explain every single item to them. And, you know, it's like, okay, you know, I've been doing this, and I don't mind having that education, but when I'm sick and I really just want, you know, to get a diagnosis and get home, I really don't want to have to go through all of that. So just be mindful of where the patient's at, and educate yourself as well. So discharge planning, referrals, and follow-up. So the biggest take home with this is that oftentimes you're going and the patient's story is now going to somebody else. So what they have just shared with you in this exam has now become, is now landed on the desk of a referral coordinator, somebody that's going to work on the paperwork element. And that means a whole other person hears the story, and that means that there's a whole lot of opportunities for additional questions. So it can be very nerve-wracking for the patient, as well as for the referral person who may not have had a lot of experience in this area. So first and foremost, identify providers in your area who may offer services that are needed by gender sexual minority patients. So things like gender affirmation services, support centers, or youth resources for younger folks who may be struggling to figure out what all these different feelings they're experiencing mean. And then even identifying what services are available for seniors, housing, home care. This can be a major stressor, especially for gay, lesbian elders. Make sure that you're including partners in planning, making sure that you're looking at the patient's family structure versus what you may perceive to be a family structure. And we all have biases, unconscious or otherwise. I am just as guilty as anybody else of having my own bias. It's important that you recognize them and work towards what you can do to be more connection with your patients. Make sure that you are following up with your patients on the referrals. What kind of feedback do you get about the referrals? Are you referring patients to providers who are sensitive to their care? If it's appropriate, maybe even reach out and call the provider that you're referring the patient to, especially if they have a particularly traumatic or difficult story. I actually had a transgender patient I worked with, and this patient had been sexually assaulted multiple times by multiple people, which had resulted in a lot of other health issues for this particular patient. And it was very hard for her to share this story. So, with her permission, she and I talked to the provider I was referring to and helped her to be able to share that story in a comfortable situation. And that made it easier for her then to get the care that she needed. Otherwise, she may have been lost to care and went into follow-up. So little things like that. And this is the important element, and this could actually apply to every single slide I've had tonight, but make sure that your staff has adequate training to provide culturally sensitive service to the patient population. Training, training, training. I know it sounds silly. I know sometimes people go, well, if you just treat patients like patients, that's fine. And it's not enough, because there's an element where you need to understand where some of these past experiences for these patients have affected them and how we can help unravel some of what's happened to them. So I wanted to just kind of end my segment here with just a few words about assumptions, which is the greatest pitfall to any type of relationship building. So a few common assumptions people tend to make when working with people who are considered gender or sexual minority patients. Heterosexuality. So number one, assuming that everybody is heterosexual and that they have a husband or wife of the opposite sex. Number two, sexual orientation defines your risk factors, not the actual behavior. So you are classifying somebody on, for example, their risk for HIV based on the fact that you either know or suspect that they are a gay man. You're not actually looking and seeing, are they sexually active? Are they in a monogamous relationship? Are they taking PrEP, for example, pre-exposure prophylaxis? And this actually was the major point that came up in the case that I had used, which was this provider saw that this patient may be gay and just went straight to that without actually assessing what the patient was truly doing. Again, traditional family or relationship status, and be open and aware that some people do not practice monogamy. They may have open relationships. They may have more than one sex partner. So there's a lot of variables that can be attributed to this. And if you're providing culturally sensitive care to your patient, it's important to recognize that it may not always be what you would expect. Sexual and gender identities are not always discussed or identified. Sometimes this whole thing is just bypassed and you go right on with your day. So make sure that you are talking about it. And I think the last assumption is orientation is a constant fixed state. So people identify as gay, lesbian, or bisexual, they are gay, lesbian, or bisexual for life. They may fluctuate. It's not uncommon for, a gay man to have had a female partner while they were figuring things out, or that a lesbian may have had a child from a previous marriage before she came out. So orientation fluctuates. I think somebody had brought up a point earlier in the evening that even as somebody is going through gender affirmation services, that their orientation may even shift as their gender identity shifts. So orientation is fluid. Just a few quick resources that you can use when you are caring for these particular populations. And then finally, if you have any questions, I know Jonathan and I would be happy to hear from you. He's got a much more fun Instagram name than I do. You can find him on Instagram. I'm on Instagram, and then our emails as well. So I'd like to thank you very much for your time and attention. I'm going to turn it back over to Nita, and then we can cover any questions as well.
Thank you both. You both had some great information to share with us. I just wanted to put a quick plug in for the IAPA membership drive that's going on now. New members can sign up for a one-year fellowship membership with the code Summer 2020, and you get 40% off your one-year membership. PA membership drives our ability as a volunteer organization to speak and advocate for PAs of Illinois. The IAPA is the only advocate organization in all of Illinois. So without IAPA, many of our laws and regulations that currently allow us to practice would not exist. With greater membership, we are able to do more as an organization. So visit www.illinoispa.org for more info. So there was a lot of activity going on in the chat through both presentations. Did anybody want to jump on and ask Don or Jonathan any question that may have been skipped over during the chat portion?
I'm just going to jump in here because I just want to address one of the conversations that was happening in the chat. The slides that Don was using of the best practices, we pulled a lot of that from GLMA from a while ago and updated it, and the word preferred got left in there a couple of times. And I think when, and if anyone wants to correct me on this, I think when we started considering pronouns and that sort of became more mainstream, the term preferred got thrown in front of it, and it really is bad. It's just someone's pronouns. It's not the preferred pronouns. It's not like my preferred pronouns are he, but like just call me whatever. They're just simply someone's pronouns, and it's simply someone's name. So I just wanted to clarify that. I think that was just an artifact from what we're citing. So thank you to everyone who is in the chat having that conversation. There's really, really great conversations happening in there. There's some rock stars in this group right now. So thank you all for sharing your experiences.
All right, does anybody else want to add anything before we close it down tonight?
So I have a question for Don, if that's okay.
Sure, please.
Hey, Don, hi, it's Diane. You mentioned you're in adolescent medicine, and you mentioned talking to your adolescents about sex. And I was curious if you could recommend around what age to start having that conversation, and what age to start having the conversation around gender as well.
So I typically will start having the conversations about sex usually around age 11. So the doctor I work with, and kind of the traditional model that the patients are used to, is they start having those conversations one-on-one with the patients at age 11. And I always explain to the parents first that I'm going to speak to your child privately. These are questions that we ask every child, so that the parents are very much in the loop, but then they are apart from that. I'll start asking more sexual, or gender questions, usually right around that time, usually 11 to 12. If it's something I kind of get a feel that the child is struggling with, I'll ask on the earlier side. But usually what I found most, I think the easiest approach with least resistance for my patients, and what makes them feel the most comfortable, is kind of having that initial year to get over the shock that I'm asking them the questions, and then kind of next year I'll expand and go a little bit deeper with them. And then usually by like 13 and 14, then we are having the full all-out conversations, but I kind of do baby steps. Like I said, unless there's something I really feel that they're struggling with, and I'll spend some more time on them.
Thanks so much.
All right, anybody else have any questions for Don or Jonathan? All right, I just want to thank everybody for joining us tonight. Thank you to Jonathan and Don for this great presentation. This wraps our Culturally Sensitive Care of Sexual and Gender Minorities webinar. Thank you again for helping us stay educated as a community. We wish everybody health and safety in the weeks to come. And remember, IAPA is here to help with any questions or concerns you have in regard to practicing in Illinois. Thanks, everybody. Good night.
Hang on. Sorry, I'm so annoying.
Go ahead.
So I'm wondering do we know about any initiatives through AAPA for improving the education and training of this sort of topic within PA programs? Because I know my program, they made some efforts, but every time anyone LGBTQ came up, it was HIV/AIDS related. And I called out my program, but that was one person that I talked to that I changed. And then all of a sudden, right after that conversation, there was an LGBTQ person with diabetes. And I was like, yes! But is there any initiative going on to improve this sort of training on the national level, on the AAPA level, with all of the programs in general? Does anyone know?
Yeah. Diane, if you're still on and you can answer that probably better than anyone else could.
I'm happy to. So there's two things. One is, the AAPA now has the new standards that are coming out in September that actually include requiring this in programs. So I'm also an educator. I'm over at the Yale PA online program, and I'm also a member of a sexual and gender minority health work group that the PAEA has organized. So whoever it is in your program, or if it's you, can get into that working group in their learning, what's that called, like the learning center online thing. And those are exactly the discussions that we're having. We're sharing curriculum tips and making it happen. So please join us.
All right, thanks for that answer. Anybody else with any final thoughts, comments, questions, concerns? All right, I want to thank you all again for joining us. I hope you all have a good evening. Thanks to all our presenters and for everybody who added little info into the chat. Appreciate your attendance and hope you guys have a good week to come. Take care.
Thank you all.
Bye-bye.